Thank you. Thank you very much, Dr. Hemant Nautiyal and his team of Himalayan Institute of Medical Sciences for this opportunity to discuss about the hernia, to discuss about what is latest in hernia surgery, and I would spend next 45 minutes on my presentation, but I would definitely encourage my younger colleagues to ask n number of questions from all the faculty so that ultimately the patient is benefited. And the topic is eTEP by optical entry for inguinal and ventral hernia repairs. What is E? Now, can we have the lights off? What is E? Anyone?
Enhanced.
Enhanced. If you tell me enhanced, then I will say extended. And if you tell me extended, then I will say enhanced. So what I mean to say, yes, you are right, absolutely right. It is enhanced or extended totally extraperitoneal hernia repair for inguinal and ventral hernia repairs. And I bring greetings from Sir Gangaram Hospital and Bhatia Global Hospital and Under Surgery Institute. If I want to convey one message, and that message is eyes don't lie. Eyes don't lie. In laparoscopic surgery, all of us have learned that when even if the surgeon is doing, but assistants are also visualizing. Initially, in our days, when we used to do open surgery, only surgeon was or may not, or maybe he was able to see, but others were not able to see, they were just able to retract. But with the advent of laparoscopic surgery, with the advent of robotic surgery, all of us have been able to see for ourselves and then make a difference. So eyes don't lie. And Jorge Dias had beautifully written an article on the enhanced view totally extraperitoneal repair for inguinal hernia repair, and this was presented in surgical endoscopy in 2012, and that changed the total scenario. Most of us, when we started our laparoscopic hernia career way back in 93, 94, then we used to do TABP. Because of the so much of wide space in the abdomen, then we were able to learn it faster. But when we had learnt about the anatomy, then we started doing the TEP, totally extraperitoneal. But again, there was a limitation of the space. But as we carried on unlearning, learning and relearning, then we could definitely do the best for TEPs. But in 2012, Jorge Dias showed that there were some challenges in TEP also. For example, as I mentioned in my oration also, that the distance between umbilicus and pubic symphysis, if it was less, then the space created was less, the mesh size was obviously had to be less, and then the chances of recurrence were higher. So if they said, he explained very clearly that, for example, you would see an artist. He would draw some anatomy or he would draw a painting, but he will go back like this and see the extended view or enhanced view, and then he will find, yes, this is the beautiful thing which I have done it. So our thinking is, and his thinking was, that if you put in the first optical port or the port from a distance and see the hernial anatomy from a distance, then obviously it will become an extended or enhanced view, totally extraperitoneal, and that has changed the total scenario. So the hernias inguinal, and this was in inguinal hernias that we could see. And in this, I would just show the external movements first and then the inside video. We are doing the hernia repair, inguinal hernia repair. What we do is that we take a 0 degree 10 mm scope and go layer by layer. And basic philosophy is, again, eyes don't lie, seeing is believing. So we carry on going without using any force, and it is between the subcostal margin and the umbilicus we are going in vertically down. Means skin, subcutaneous tissue, camper, scarpa, rectus, anterior rectus sheath. And as you see, the anterior rectus sheath has been crossed then one sees the rectus muscle, and at that stage, now you see the change in the angulation. Now we'll change towards the pubic bone, pubic ramus, and then carry on going inside and doing the dissection also with the glass tipped trocar. This is a glass tipped Ethicon Johnson Johnson OptiView trocar, and with this we take the fullest advantage, because initially we were using the PDB balloons, then we were using the saline. But when we started using this eTEP or OptiView and then we connected with the gas, it would automatically form a space for us, and then we could glide in over the posterior rectus sheath, and we could go up to the even arcuate line, arcuate zone, and then we could go up to even the pubic ramus. Then we realized that if we, now you see the movements, outside movements, when we realized that if the patient height is more, then the long length repair, so that when we are laying down the mesh, it has crossed 2 centimeters beyond, and it has gone to the cave of Retzius also. Now we are coming to the arcuate line, the posterior rectus sheath. Again, many times, many surgeons would ask us that when we were doing TEP, we were not cutting the posterior rectus sheath. But why are you cutting now? Why are you making it weak? No, our thoughts are that now you see this is a white peritoneum lining. So if you are able to see the peritoneum clearly, if you are able to make a space, so big a space that 15 by 12 centimeter mesh would rest comfortably, there is no point in cutting the posterior rectus sheath. But if the patient's span is less, if the height is less, there may be some situations when we are not able to unfurl the complete 15 by 12 size mesh, then definitely one has to cut the posterior rectus sheath lateralmost, uppermost corner, so that when we are laying the mesh onto the floor or onto the roof, then it is covering it nicely. In this situation, as I mentioned, we believe that we should fix the direct sac onto the Cooper's ligament either with suture or with the tacker, so that ultimately the seroma incidence is definitely decreased. We fix it onto the Cooper's ligament with the help of tack. Again and again, my intention is loud and clear that the inferior margin of the mesh should rest absolutely comfortable. It should not get rolled in or rolled out, because as we have demonstrated, that is the commonest cause of recurrence, that if the peritoneum goes behind the mesh, and that will lead on to the hernia recurrence. And now we are unfurling it, but again, because our 2 ports are infra-umbilical midline, whether we are doing right side or left side, we make these 3 ports only. That means 1 port, it is higher up, and second 2 ports are in the infra-umbilical region. Now, if for example, now we are in this video clipping, we are doing the bilateral inguinal, then I am standing on the left side. If I am doing bilateral, then also I am standing on the left side, and the first entry is between the subcostal margin and the umbilicus. And if we draw a line and center point of this, because if you start going lateral to the linea seminaris, then you will injure the neurovascular bundles, and that will lead on to weakening, and that will also. Now in this small video clipping, I am just going to show that previously we had done the left TEP long time back, and now patient has come back with right inguinal hernia. So we are going to make a port on the right side. Why should we go on the left side when the hernia is not there? One. Second, the mesh has already been placed. So again, when we are using the 0 degree 10 mm scope, going layer by layer, and there are instances when if you are using the force, then you can go into the anterior rectus sheath, rectus muscle, and then you can go into the posterior rectus sheath also, and then into the peritoneum. So one should be cautious about that. And you are going into the posterior rectus sheath without the pneumoperitoneum, and then you can cause some injuries. So our thinking is that at this stage, once I have crossed the anterior rectus sheath, the rectus muscle, then slow down, have a 360-degree rotation. As soon as we are able to separate the muscle fibers of the rectus muscle, then change the direction slightly. You see that? Change the direction and slightly withdraw it, and then carry on grazing over the posterior rectus sheath. Now you see, grazing over the posterior rectus sheath, and with the help of glass blade. I am just going into the detail because these are the small challenges you would face when you are doing the eTEP inguinal hernia, for inguinal hernia also, for ventral hernia also. That is the reason that I am emphasizing that we are keeping the glass bladed trocar slightly horizontally now, so that it is cutting and we are avoiding any injury to the blood vessels, and then we are going in. Yes, there can be some situations. For example, if your direction is towards on the anterior abdominal wall, you can injure the inferior epigastric vessels also. That should not be done. So unnecessary bleeding should not be there. Unnecessary should never become the red. And once we have taken care of all the loose areolar tissue up to the pubic ramus, if you are able to go, you see that? Now again, with the help of slight force, we are just dissecting into the retrorectus canal which has been created, and then we are going, now you see, and then we are withdrawing our scope, withdrawing our port also, so that we are able to see the medial border of the rectus abdominis muscle. Once we are able to see the anterior border of the rectus abdominis muscle, medial border of the rectus abdominis muscle, then we make 2 more ports and do the surgery in the same very manner. Again, there is no point in dissecting the mesh which has been previously placed on the left side. So we should make a space on the right side and then do the same way as it was shown in the previous video of left-sided inguinal hernia or bilateral inguinal hernia. And this was the GPS or the syringe or a needle which we were using. And with the help of this calis, we just break the anterior rectus sheath in the midline also, so that when we are putting in the ports, we are not putting lot of pressure from outside. If we put a lot of pressure from outside, then the chances are that we may perforate the peritoneum, and if the peritoneum gets perforated, the space is already limited, it will further be limited by this port, and that will become a challenging situation unnecessarily. So our thinking is just break the fibers with the help of calis, so that we are not using any port. And especially for my younger colleagues, I always tell them that if you are using any force in laparoscopic surgery, you are doing the wrong way. Anywhere and everywhere, it is the same dictum as that please do not use any force. Now once the ports have been placed, and then we will carry on dissecting the same way as we have done it before. But make sure that we are working absolutely close to the arcuate line and arcuate zone. Now is the time for ventral hernia. Can you imagine? 5 years Jorge Dias had described about eTEP or extended or enhanced view. But after 5 years, Igor Belinsky and Dr. Ramanna and Dr. Victor Radu and so many surgeons, they collaborated, Yuri Nowosky, and they gave this novel approach for laparoscopic retromuscular hernia repair or ventral hernia repair, and that ultimately has changed the total scenario. And in this video clipping again, I will just show that one, we are going in for ventral hernia repair, but in this situation, many times many surgeons were making 3, 4, 5 ports for doing the ventral hernia repair. Now in this situation, can you imagine, can you appreciate that? This is an infra-umbilical large ventral hernia, incisional hernia, and then we have gone in, we are going to go in with the OptiView, but we are making only 3 ports. Initially, when we started our eTEP ventral hernia repair, then we were making maybe 4 ports or maybe 5 ports, but gradually we have also now been doing only with the 3 ports, and in this we are showing on a 2x speed that we are going in OptiView 15 centimeter, bariatric length 10 mm, 0 degree scope goes in, and then we as we go in, anterior rectus sheath gone, posterior rectus sheath seen, posterior rectus sheath not punctured. If we puncture it, then obviously the pneumoperitoneum will occur, and that will, yes, you can still go ahead with surgery by making the patient head low and by putting in a various needle through the palmer's point. But still, it is a good thought not to perforate it at the initial phase, because if you perforate the peritoneum, then the pneumoperitoneum definitely hampers. Now you again and again visualize that the glass blade trocar is making a space for us. So means either you would do it by placing the 2 secondary ports, and then with the help of graspers, 2 graspers or harmonic and grasper, you will make the space, or you can make it just with the optical view entry. And for that, it takes not more than 2 to 3 minutes to make or to create that retro-rectus canal. And in this situation, are you able to appreciate the medial border of the rectus abdominis? This is the medial border of the rectus abdominis that is being seen. And then we are withdrawing our scope. At this stage, we are withdrawing our scope so that we have enough of retro-rectus canal on the left side. This is called as arcuate line and arcuate zone. Means the posterior rectus sheath also does not end suddenly, but it has few fibers and gradually decreasing fibers, and then only we are able to go in. So once that space has been created, now the 2 secondary ports again have to be placed just close to the linea seminaris. That means you should have dissected on the lateral aspect of left linea seminaris, and then with the help of syringe and needle, we should always judge whether we are going to, where exactly are we going to place in a port, second port and third port. Now initially when we started our eTEP ventral hernia RS surgeries, then we used to make one 12 mm port in the in subcostal region, another 12 mm port in between, and then 5 mm port. But now we are using the 5 mm scope, so that means we have 2 5 mm ports and one 12 mm port. And once this space has been created, again and again I am just emphasizing the importance of the red meaty fibers of the rectus abdominis. One can appreciate the red meaty fibers, and this is the inferior epigastric vessels. One can see we should not cause any injury. Now you see, any injury to the inferior epigastrics, any injury to the neurovascular bundle also. So if you cause any injury to the neurovascular bundle, then unnecessary ooze will be there, and that will spoil the field also. Now again, once this space has been created, we are trying to go down, and we should be able to see the White House or the lighthouse going down. Again, the intention is, when we have created this space, we are using the harmonic A's to or the monopolar or bipolar to the minimum, not barbecuing the complete tissues. And then once we have been able to see the inferior epigastric vessels, once we are going into the cave of Retzius, because this patient was having a infra-umbilical incisional hernia, so it is imperative that we place in a mesh up to the Cooper's ligament. Most common cause of recurrence is that if you do not place the mesh into the cave of Retzius, these infra-umbilical incisional hernias are, I would say, notorious for recurrences. Or if it is a large hernia, then the mesh may migrate up and then cause a recurrence or a pseudo recurrence. And then once we have been able to create that space, then one may change the position of the camera. Means now you see that we have taken the camera down 5 mm scope, and then with the help of a hook from the subcostal port, we are putting in a hook, a monopolar hook, and we want to cut the posterior rectus sheath 5 mm to 1 cm away from the insertion. Means now you are able to see the rectus, posterior rectus sheath. We are giving an incision. We do not want to again cause a pneumoperitoneum. We wish to make an incision onto the posterior rectus sheath, and then we wish to see this yellow fat of the falciform ligament. Again and again, intention is that if you are too far off from the junction at which the medial border of rectus abdominis is, then you will cause the injury to the pneumoperitoneum, and that can spoil the field. But if you are just making sure that with the heel of the hook, not with the hook of the hook, but with the heel of the hook, if you are incising, then one can appreciate the fatty triangle formed by the falciform ligament, and then with the help of grasper on the left side, camera is in between now. That means 3 ports are there, camera is in between, left side is having grasper and right side is having hook, and then we are making the falciform ligament go down, and then we are trying to cross over. This is called as superior crossover. So we are going with the help of monopolar, with the help of grasper, we are just withdrawing or retracting the tissues. Now, this is the situation that one can cause mistake. Mistake in the sense that if I am able to see the left rectus muscle and I have given the incision onto the left posterior rectus sheath, but now we have to make sure that we do not go far beyond and then give an incision onto the posterior rectus sheath and then see the transversus abdominis. No, our intention is to, with the help of hook, we just check from outside also, and the color of the muscle is also seen, and with the help of hook we just give a small incision, and we should make sure that the muscle fibers of rectus abdominis are being seen from going from top to bottom rather than the transversus abdominis. I will show a small video clipping afterwards that in one situation I had gone into the slightly more rectus sheath, more lateral to that, and then I was thinking that I am dissecting close to the rectus muscle, but it was a transversus abdominis muscle. So, but again, after doing some dissection, we realized that the muscle fibers are going in a lateral direction. That means they are transversus abdominis muscle. Now, in this situation, as you would see, that we are just giving an incision onto the right side of the posterior rectus sheath. The rectus muscle is on the top, and then we are inching towards the defect. That means from the top we started, we are going towards the infra-umbilical area where the herniation is there. But there can be some situations, if you are in a hurry, if you are not having patience, then you may injure the bowel or the peritoneum or cause pneumoperitoneum, and that again will limit your space. So believe me, lesson number 1 is patience, lesson number 2 is patience, lesson number 5 is patience, lesson number 10 is patience. So we carry on working with patience towards the goal, then only. And the basic thoughts are that you should not operate with clock in mind. You should operate with compass in mind. Means the direction should be right. So if my direction is right and the posterior rectus sheath is being cut, then we are nearing the defect area. Again, once we are taking this fat also onto the posterior rectus sheath away, then we are trying to go towards the linea semilunaris, just with the help of small, smart bursts of current. Small, short bursts of current that we are able to see and go up to the linea semilunaris. We do not want to barbecue the neurovascular bundle, and then once we have made sure that we have reached the right linea semilunaris, we had already seen the left side of the linea semilunaris, and now we are going towards the defect. Now this is the area where I should be again very careful that we are going bit by bit. Small bites, small mistakes. Small bites, small mistakes. Means we are giving a traction with our left hand. The posterior rectus sheath on the left side is seen. With the help of heel of the hook, just we are making sure that and plus again and again make sure that we are not injuring the muscle, we are not injuring the vessels, we are not making it a red meaty environment so that we are not able to see the details of this eye. So we are working close to it, and now is the time. Most of us go with the thought that we start thinking that eTEP means totally extraperitoneal and it will remain extraperitoneal. No. At this stage, yes, one has to make sure that we have to go transperitoneally also. Once the access has been made by eTEP approach, then we go transabdominally, and if we are able to save as much posterior rectus sheath, as much peritoneum, and we are able to safeguard the small bowel or the bowel inside and take the contents down, then only one will be able to justify the eTEP. In this situation, what negative things can happen? Negative things can happen is that we injure the linea alba. If we injure the linea alba with the help of a hook, means I start not here but I start here. And then if I injure the linea alba and the subcutaneous tissue, and then you will be able to see the sky also, or the OT lights also. So one should not be able to see that. One should not go into that space. So linea alba has to be preserved. Linea semilaris has to be respected. Neurovascular bundles should not be damaged. And then, as you see, the posterior rectus sheath, we are taking it down. One can use the harmonic, one can use the ligature, one can use the monopolar, but we believe that in this kind of traction and counter traction, hook serves a good purpose. But again, you would appreciate that this hook is also having the titanium. Means it does not, it has a bakelite kind of insulation. It should not touch so much of area. So as we are going in, now again follow the white, you carry on, and our aim is to go into the cave of Retzius. Once we are able to go from the right side into the cave of Retzius, from the left side we have already gone into the cave of Retzius, and then shake hands so that we have made sure the hernial contents have come down and the two spaces of inferior crossover. This will be called as inferior crossover. They are also shaking hands with each other, and then we will be able to place in a large size mesh. Again and again, we are making sure that we are not causing any injury with it. And here one can appreciate, this is the peritoneum. Now you see, this is the peritoneum lower down, and making sure that we are remaining close to the medial most fibers of the right rectus muscle also. And with the help of my left hand, we are giving the traction down. Then now you see, again and again, we are nearing our goal. And once we near our goal, then if for example, if the intestinal contents are there, one has to be very, very cautious. And for that, I would advocate, especially my younger colleagues, please do not read these CT scans. Do not read these CT scan reports. You should always see the CT scan your own self, because you are in a better position than even a CT report, radiologist report also, because you will be able to see beforehand, that means before the surgery, and perioperative also, you will be in a position to see whether the intestines have gone in or not, whether the intestines are adherent or not, and then post-op also, again go at the view box and see for yourself what did you miss, where was the rectus abdominis, whether there was a divarication or not. In such a situation, in such a patient, if it is a large infra-umbilical incision hernia, there was a divarication, which we had seen on the CT scan also, and then we go in so that we do not cause any injury. I know the surgeries have been done elsewhere and they have caused injuries to the intestines, and it has gone unnoticed. Worst problem is that if the iatrogenic enterotomy has occurred and it has gone unnoticed, then patient presents on day 4 or day 5 with peritonitis, and the incidence of mortality increases by 40%. So one has to be very, very careful. This is the, I would say, the thought, especially in our senior surgeons, that when we were doing the IPOM or IPOM plus, we were seeing the intestines right at the word go as we went in. But in eTEP, we have made such a big space, still we have not seen inside, and that was the reason of making the senior surgeons convert into a eTEP very fast. So again, now you see the peritoneum is being taken care of, the contents have already been reduced, and then again it has to be bimanually palpable also. That means we are pressing from outside on the contents, going ahead with the hook, and then we should not cause any injury to the right inferior epigastric vessels or to the left inferior epigastric vessels. And why I am at the moment interested in not injuring the peritoneum or not injuring the posterior rectus sheath, because in the end I have to close it. If it is a large defect, if I have created a large rent in the peritoneum or in the posterior rectus sheath, in any case the posterior repair has to be done. So I will have to do the suturing. So make sure that you do the minimum suturing for minimum rent, and so that again the thought process is think 2 steps further up or anticipate challenges, that if you are not able to close the posterior rectus sheath nicely or the peritoneum nicely, then the mesh will attract the intestines, or the intestines will attract the mesh, and they will get adherent, and the patient will have subacute intestinal obstruction. So again and again, aim is do the minimum at that level, but do not cause any injury. Now we are inside the defect. We are making sure that all the adhesions are taken care of, and at this stage, yes, one may change to the harmonic or to the Sony. This is a Sony season which I am using at this stage, and with the help of Sony season, with the help of monopolar or bipolar, one carries on retracting the tissues down and the contents down, and then once we are able to make the space, then our next goal would be to do the posterior closure and the anterior closure. Which one to do first? Anyone. What I mean to say, there are surgeons who will always go in for posterior rent closure first, so that ultimately they know that it is a limited space by putting the pressure down, so that we are not leaving any space for posterior rectus sheath disruption later on. But there are surgeons who would go in for closing the anterior rectus sheath first. That means the divarication first, and then once they have been able to approximate the rectus to rectus muscle in anterior fashion, then if they go on the posterior side seam, anything can be done. What I mean to say, there are no fixed rules of the game. You can always make sure. Now you can see the most of the contents which were present, they have been taken down, and most of the sheath has been also been taken out, and there is a rent, and there will be some situations in which, for example, if we want to close the posterior rectus sheath from bottom to top, then we will not be able to do it. In this situation also, once the unification has been done, the rectus muscle on the right side, rectus muscle on the left side has been seen, then we are going to close this rent in a transverse manner. Again and again, aim is that it should be closed, and it should be closed without any tension behind. Once I am not able to fast forward that, but it's fine. Then once we are able to create that unified space, then we will do the suturing. And suturing has the advent of the starta fix or the barbed suture has definitely helped us, in the sense that it definitely becomes challenging to put the sutures on the roof. But if you decrease the pressure to maybe 9, 8 or 10, then you will be able to suture the roof also, and one has to start from a distance and go proximally. As Dr. Magan was also showing, robotically definitely it becomes easier to suture onto the roof, but laparoscopically one has to learn the art of, but again, as I mentioned, if you are having some difficulty, some challenge with those 3 ports in suturing, then one can make another port on the right side in the retrorectus canal and then place the camera in between, so you can do the suturing from the top also. And if once we are able to do the suturing from below upwards, then one can take another suture from the top to the bottom, so that we do not leave any divarication behind. If we leave the divarication behind, that will again make a challenging situation, and you have already gifted the patient with one more hernia. So that should never ever be done. And then now we are entering the Bogoro space. Again and again, making sure that we are not causing any injury to the vessels or to the nerves. I wish it could be fast forwarded at this stage, but it's fine. Now you see the defect is there, and we will have to close the defect. And once the anterior divarication and the hernial defect has been closed with the barbed suture, then we will close the posterior also. Then we have to measure the mesh. We always say you cannot manage what you cannot measure. So measure it with the umbilical tape, and one has to take a distance between the left side linea semilaris and the right side linea semilaris, and take from epigastric region, from the xiphoid process to the pubic ramus, and then only we will be able to know the exact dimension of the mesh which we are going to place. Maybe 30 by 50 or maybe 28 by 15. We should take a large size mesh, and normally we would not put any tacks. Normally we would not put any glue also, but we will place in a mesh in such a way that it rests comfortably once the pneumo extraperitoneum has been taken care of. And I think in the interest of the time, I will go to the next video so that we are able to have some questions also from the floor. Now you see that again, this is a small video clipping, but for example, in this situation, initially only we have caused some rent in the pneumo, and then it becomes challenging. Not that we are not able to do it, we are able to cross, we are able to do it, but now you see the pneumoperitoneum has occurred, so one has to have excellent team of camera surgeons also, and the camera person, as Dr. Hemant and we were discussing, that one has to have the proficient cameraman also, and especially that cameraman who can handle, he or she can handle the 30-degree scope, because most of these surgeries are being done with 30-degree scope. And believe me, we have many observers coming to Gangaram Hospital as well as to Bhatia Global Hospital. Many times, many surgeons, many senior surgeons feel confident. No, sir, we have handled the 30-degree scope a lot. But once they start handling it, then only in one pressing of the key of the piano, the expert can know how much piano other person was playing. So that is the way. And this is a small video clipping in which I am just showing that I caused an injury. I had gone on to the posterior rectus when I was doing the superior crossover. Then I had made sure that I was using the harmonic at that stage, and I was making sure that I am able to see the falciform ligament, the fatty triangle, but I may have not seen the CT scan properly. That is the reason that I would carry on going on the lateral aspect and carried on, and I saw this muscle fiber. You see this muscle fiber? So I thought that this is a rectus abdominis muscle fiber, and then I started cutting the posterior rectus sheath. But after dissecting to some length, then I realized that the posterior rectus sheath was not the posterior rectus muscle was not the posterior rectus muscle, but it was the transversus abdominis. And you can appreciate in this diagram also the transversus abdominis is medially placed higher up, but then it becomes aponeurotic and then it appears on the lateral aspect laterally. So one should be very careful and one should try to learn, but at that stage we learnt it that we have caused a mistake, and then we became medial, and then posterior rectus sheath could be easily cleared. So thank you very much for your kind attention. Any questions if you have, you are more than welcome to ask. Thank you.
Seeing is learning. So, but I think majority of you had a good nap also, I was noticing. But in between you were awake also, so you can ask questions wherever, you know, especially I think the last part, which is very important, that how you can avoid injuries or the mistakes.
Dr. Raj, please.
So my question is about the initial part where you place the trocar and jain entry, the trocar based entry. So you use the XL port. What is your experience with the other ports?
Good question. Frankly speaking, we took over the OptiView long time back, maybe 20 years back when it was launched, and we have not been using the reusable ports at all. But I know there are surgeons who make the first entry with the skin, they apply the S retractors, then anterior rectus sheath, then they insert their finger in and they retract the posterior rectus muscle sheath behind and rectus muscle laterally, and then make an entry with the metallic port. But honestly, I feel many times, not that I have been doing it, I have been doing eyes don't lie, in laparoscopy also, in lab chole also. I do 90% of my lab choles as single incision lab choles. So I always do with the OptiView. So our thinking is that nothing like OptiView, but if you are not able to do it, then finger is the instrument, then the reusable trocars are also instruments.
So there are other OptiViews also from other vendors?
Absolutely.
So any experience with
Yes,
those?
yes, I have the experience of, again and again, the caution is the distance between the glass blade and the tip of the 0-degree telescope should not be long. There is another company, I will not name it now. There is a company in which the glass blade is slightly, maybe 1.5 centimeters away from the tip of the scope, and that again becomes a challenging situation in my mind. I feel that it should be too close, and then we are able to injure or not injure.
So that's the problem I face, because whenever I use the ports from that particular company, I have always used to have an entry into the posterior sheath.
Absolutely.
Excel I don't get a problem, but with the other ports I always, that's why I shifted.
Wonderful, wonderful. And this is the experience which nobody of you will be able to solve it till you listen. Once you start listening, then you will see that yes, these kind of challenges can come. I initially 1 or 2 stages in eTEP RS also, I had gone in, and 360-degree rotation. I crossed the rectus muscle and then I went into the posterior rectus sheath also. And then I realized what has happened. And then once I withdrew, changed my direction, put the pneumoperitoneum venous needle, and then I could proceed. So what I will say that safar mein nikle ho, dhoop to hogi.
Another point was I saw that you placed the first port OptiView almost in the middle of the rectus bulb.
No. A good question. Yes, good question. Very nice question. This was maybe initial experience, but now our thinking is that what I do is that I place one finger on the pubic ramus, another thumb onto the anterior superior iliac spine. So this midpoint, that means like this. So pubic ramus, the anterior superior iliac spine. So this becomes a mid-inguinal point. So I draw a vertical line, mid-inguinal point, I reach the subcostal margin. So I have to be medial to the linea seminaris. I should not be too medial. Yes, you are right in picking it up. Good, excellent. You should not be too medial, because if you are too medial, then also you will not be able to see the posterior rectus sheath insertion at that stage. So it should be from a distance. And again, you should not be too lateral to the linea seminaris. In one situation, I have done this injury also. I had shown that video before in some conference, that I had gone maybe my attention was not towards this, but I was seeing the monitor, and I carried on going in with this movement, and I realized that I have gone into muscle, then again another muscle. So I was surprised, what is this next muscle? And this was obviously external oblique and internal oblique. Then I changed my path, and then I started moving medially. Very nice question. These are the practical things that one has to. And please do not think that it does not have a learning curve. The persons of his experience, of Dr. Nautiyal's experience, my experience, also can make mistakes. But if we have discussed this, and if I am venturing into the new surgery or this kind of surgery, then definitely if I am careful that I should respect the linea seminaris, I should not be going into lot of bulk of the muscle, but we are going laterally, then definitely these complications or challenges will be less. Very nice.
So the last point, for the right side, you put the scope on the right side only, and for left, you place the scope on the left side only.
No. Again, very
Because
nice.
what you had
Yes,
said
yes,
was
yes, yes. Good. I must appreciate that he has listened to the lecture very carefully. One. But second, I explained also, if I am doing left sided inguinal hernia, and I am making the same entry as I mentioned, in between the umbilicus and the subcostal margin, midpoint, medial to the linea seminaris, that is my first entry. If I am doing this bilateral, again this is the entry. If I am doing right side, again this is the entry. Because I am more comfortable by standing on the left side of the patient. But this was a situation, this was a video clipping in which I showed that I had already done eTEP, TEP on the left side first, many years back. And now once we are going in for the another right sided hernia, so why should I go into the mesh and dissect and then crossover? Is it good idea to go from the right side? But again, the rule of the thumb is go from a distance, wherever you are comfortable with. There is no fixed rule that every time I should go from the left side. I am comfortable with left side, but if you are comfortable with right side, yes, go ahead. But there are situations, for example, if you have to go in for the right side, again follow the Optical. Again take 10 mm scope, go with the Optical so that you are not going into the peritoneum.
So that means you, after you place for right sided hernia, inguinal hernia, you place the telescope on the left side, then you shift your position. You go to the opposite side to operate on the left side.
If I am operating on the left side, then I am standing on the right side. If I am operating on the right side, then I carry on remaining on the left side. And these two secondary ports are infra-umbilical. Yes, I know there are surgeons. I know there are surgeons who make one infra-umbilical and one lateral or one lateral. So that means they make 4 ports for bilateral hernias. But we make 3 ports with bilateral hernia. There were some objections in the beginning when I was doing the workshops, lot of workshops. Then people used to say that why are you making infra-umbilical, it becomes challenging. My answer is, it is an experience. If you carry on doing the same thing again and again, yes, you may do the wrong things again and again also, but if you have been doing TEP for ages with the infra-umbilical ports, that becomes easier. And for us, suturing is also easier if I have to do it.
Regarding the crossover, I found that initial cases I found very useful if I marked it preoperatively with the ultrasound. We had intra-op ultrasound.
Yes.
I just marked the medial position and then go. Now it's easier.
Yes, very nice. It is a good thought to have the ultrasound and know the ultrasound also. Today, ultrasound is our stethoscope. Is the surgeon's stethoscope. So one should know and one should learn from even the anesthetist also who are giving the tab blocks. So we should always make sure that we have the ultrasound. If you don't have the ultrasound, then marking is better. It is better to mark the linea seminaris by feeling it, marking approximately 7 centimeters, and then remain within linea seminaris rather than going outside the linea seminaris. Yes, Dr.
Good afternoon, Dr.
Yes.
Dr. Bhatia, Dr.
Oh, Atul, how are you?
So, same questions, different point of view.
Good.
So, first of all, about the optic port, I routinely make a skin incision by knife. We make a very small hole with acid retractor on the retractor sheath. We don't even make a bigger hole. We dilate with artery forceps, put a finger, create, I will show you the video tomorrow. I'm going to show all the videos tomorrow. And we create a very good space. Why I'm saying that this is, I feel safest, and optic view with a safe hand like Dr. Bhatia is always good. But you remember the case in, so you know what I'm saying. So we have seen so many serious complications, bleeding, perforations, bowel injuries, and for the masses, optic optic view is not as safe as seen by masters doing it in a picture perfect way. There's a lot of complications. Even we had a very serious experience with that. And that is why I feel, and plus it saves cost, and it's very simple, very easy. I'll show you the video. So, I mean, that is my view, but obviously optical, if you have mastered that, then nothing like that, eyes never lie, so that is perfect. One view, I mean, Dr. Bhatia will
No,
agree.
it's absolutely right.
Because that time we had a very severe bleeding. And
Sure.
second thing is that about the eTEP. About eTEPing, well, I do it in a way because I always feel that if I am doing a right-sided unilateral inguinal hernia, I have no business to start from the left side. Why? I will tell you. Because suppose this patient which was showing reoperation was previously operated by TEP. Suppose he would have been by eTEP, what would he have done?
If he was done by each.
Suppose eTEP was done on one side, what you have done? Because you have already breached and disturbed the anatomy. So what I do, I'll show you a video of this again tomorrow, that we follow, that we operate from the eTEP inguinal hernia, same side. So what we do is, we put first camera port on the same side of the hernia, above and lateral to the umbilicus. You create a very good space. The orchidites and other people, South American, they were very cosmetic conscious because they go to beach with, so they were making umbilical incision. But we realized that this is fighting with the camera. So we made the incision 5 centimeters below the umbilicus. And third incision we go on the right side laterally. So we remain on this side, we don't cross to that side. And if we have to do bilateral, we can do same port. I'll show you the video tomorrow. So I don't do from this side to there. I do it, I'll show you the video. We start from here, first port, second port intraumbilical, third lateral, no going to the away of the midline. Stay in that area, don't breach that area, and you will not be disturbing. Suppose you have to do surgery again, you are not doing anything. So it's very easy. I'm doing it, I'll show you the video tomorrow. And you don't have to go from other side. That is my view. Yeah.
Sure. No, I appreciate that. There are n number of methods of belling a cat. But again and again, one important goal is, as important is, yes, one has to remain safe. And because we have been using the OptiView for a long time, and we have been using for pneumoperitoneum cases also, for in which lap chole or hernias or whatnot. But because of venous needle, the pneumoperitoneum was there. But if the pressure was not there inside the abdomen and you are going, yes, one has to be very, very careful that we do not perforate the posterior rectus sheath and then we graze up onto the posterior rectus sheath. Good. Excellent. Yeah.
It's always a learning from your presentation. As you said, so the midline, I am using the same technique. Initially trained by Chobesers, infraumbilical course or camera also.
Sure.
Then shifting back, it made very easy to unfurl the mesh upper margin. That is the one. So once you practice midline port, they become very easy for the bilateral ports, whichever side you are doing, as you said. So my question is, if you see the dynamic mesh, so they have a curve. They are not square or rectangle, 15 by 12, so they have a curve. So, but you didn't design or refashion the mesh like this. I have started after seeing that mesh. Dynamic meshes I cut laterally, so it unfurls very well. So what is your experience like?
Yeah,
It should not be done, or because I picked this practice, I said when the company is making, they are not making a rectangular mesh. They are having a slight cut on the lateral
No,
side.
but my answer
It's
to
a contoured mesh.
Yeah. My
and
answer.
one thing is that because that contour indirect hernia is prevented by the lower fold, direct hernia is on the medial side. So what is the sense of having a whole mesh towards laterally till the anterior square spine? So that's why contoured meshes, dynamic meshes are curved on the lateral side. So I started doing this, and it's not a long follow-up, I will say, but they unfurl very well, and you don't have to dissect unnecessarily laterally, because all recurrences are noticed from the medial side. They are never from this side. So we are doing, what I perceive is we are doing unnecessary dissection laterally to trying to
I
place.
think the dissection has to be the same.
Yeah,
The mesh
dissection
may be
is-
different.
Absolutely.
The only advantage of those meshes, what I feel is, they open up very easily.
Very easy.
So if you have the flat mesh from a good company, they also open up very easily.
And the meshes do come in different sizes. I fully agree with Dr. Rajiv. The dissection will not change.
Yeah, dissection.
Yeah, mesh you can change.
Yeah,
No, our experience has been,
Yes.
you would remember the barred meshes.
Yeah,
The
exactly.
barred anatomical meshes had
Yeah.
come in the initial phase. But we used it And we realized that the size of the mesh was less than it would have been. And then we requested them, then why are you making 12 by 10 centimeter mesh? It should be a larger size. Now they make 17 into 12 size mesh also. And that is an adequate issue. So our thinking is, you have to make sure that you are covering the whole of the myopectineal orifice, and as Dr. Rajdeep has also pointed out, make a good space for the mesh to rest comfortably rather than curling in or curling up or curling down. Yes, definitely. And the dynamic meshes and this dynamism will continue. Let's go to the final stage when patient does not have any recurrence after hernia repair. Good.
Thank you very much. You want to?
No, no, sir.
Thank you very much, sir.
Thanks a lot. Thank you. God bless you.